I try to my endoscope surgery more easy and reproducible. So one of the method is palpating bone with the instrument, blunt tip, palpating bone, and is the surgical anatomy, because every nerve is under the bone. So firstly, I touch the bone, lateral facet, transverse process, internal space, and then put the endoscope and continue my surgery. So this is actually I feel I become small man because great surgeon's presentation made me small. So this is actually I am a decompression, and my biggest surgery is interbody fusion. So personally, is bipolar. I have over 200 cases of interbody fusion, and I have two types of interbody T-lip. So I will talk about that. So everything is the same. So picks of bipolar or unipolar interbody fusion is the same as two microscopic T-lip. After removal of facet joint and putting the cage. I have two types of surgery. If we need a spinal ULBD, it means the spinal canal compression stenosis. I have some different style, and there are no only foraminal stenosis or instability. I like to use Cambin triangle interbody fusion. So you know very well, this is Cambin triangle. So there are no canal stenosis. I like to have skin incision from lateral wall, from 1 cm lateral skin incisions, and try to, and always this skin incision include disc space, because this is an endoscopic surgery, so skin incision is small. So if your skin incision is a different area, you cannot put the cage. So always your walking port include disc space. It is very, very important. So after removal of SAP and inferior part, drilling of inferior part of IAP, we can make annulus, exposed annulotomy about 2 cm. So with the 2 cm, we can put the cage, olive cage or all kind of cage. Just before I showed this video. So this is my and before operation, I always this is very, very important. This parallel to the disc space, and draw your drawing of a skin incision is very important. And I'm also this endoscope surgery, L5S1 high sacral slope. I like to stand. I recommend you stand the right side. And if you need ULBD, please stand the left side, because ULBD with the bipolar left side stand is much more easier compared to right side. So and I would like to recommend you, if you are annulotomy too medially, put in the big cage, your nerve is over retracted. So post-operative put dura or other things. So I recommend you only lateral marginal dura. Okay, annulotomy too medially lead to the over retraction of your nerve. So lateral margin or 1 mm, 2 mm medial is enough for the annulotomy. So I like this is 1 cm. I'll use this one, 1 cm, 2 cm, making annulotomy 2 cm to insert the olive cage. I have experience for the long peak cage. It is 45 and wide is 16. And this is 50, or wider is 18, and this is expandable cage. So experience for bipolar insertion of a cage. So this is my experience for the expandable cage, which is Korean made. It is we can make generation. Generation means if your expandable cage is fixed and fixed lordosis and single direction expansion. We call this first generation. Second generation is we can adjust the lordotic angle from 0 to 12. We can start at 7, 6. We can adjust the angle. We call it adjustable lordosis. This is a second generation. And if your cage is dual expansion, vertical and horizontal, we call this is third generation. You are in the US, there is a third generation dual expansion cage there. And if you are dual expansion with adjustable, it is a fourth generation. It is not in the market. It is in the developing stage. So Korea made is only vertical expansion with adjustable lordosis, second generation. And they use, they developed the BMP2. The biggest handicap for endoscopic interbody fusion is BMP and orthobone is wash out because always there is a movement of fluid. So bone graft or BMP material wash out. So they developed the putty-type packing, injectable packing, and caps to prevent the washout of BMP. This is my videos for ULBD. The skin is just lateral wall because we have to do ULBD, and I like to have a finger dissection of facet joint, and with the RF, radio frequency, exposure and dissection of joint, and here is the interlaminar space. Usually left side standing, I like left side standing, and ULBD first, ipsilateral laminotomy, and the same method with the butterfly technique, find the head of butterfly, and the separation and the sublaminar release of a contralateral side. Is this egg-shaped drill is very useful for the contralateral sublaminar release. And I try to expose the contralateral medial wall of SAP, and the separation of ligament from contralateral SAP, and distal margins, distal lamina, and try to remove the ligament flower. And then I try to separate the facet joint with the drills and the break. I like to have a medial to lateral breaking. If I have experience for medial to lateral breaking, it's very easy to go for pedicle because this is an endoscope. Endoscope is some deviation over the view. So I like to IAP removal from lateral to the medial. And the next step is breakage of SAP. This is a breakage of SAP from medial to lateral and we can expose the disc space. This is a tip of SAP. So finally we can make the extended cambium triangle. So from lateral to disc space to the medial oral dural we can make annulotomy, 2 cm annulotomy is possible. And big advantage is making fusion better. It's very wonderful. And this is the anterior part of annual. Some doctors want to have an anterior release from posterior approach, but I don't agree with it. And then we can put any kind of cage, expandable cage, long peak cage, double peak cage, and only cage. Now I'm starting to the fusions of expandable cage using BMP2, and this is the orthobone which came from the facet joint. Okay, and I am making some follow-ups for videos. And this is the MRI of print of MRI. So long large peak cage, and this is the olive cage. This is the expandable cage. Expandable cage has some limitation for the small footprint, so we need some BMP or other materials. So this is my video, my X-rays, my case for ULBD and putting olive cage. This is expandable cage. And I have experience for, I also have interest in, so one level is peak cage, one level is expandable cage, the other level is olive cage, and the comparison of fusion status. So, and immediate post-operative correction of lordosis and other clinical outcomes, I'm studying it. And this is my experience for interbody fusions with the navigation systems. With a single skin incision, ULBD, and foot cage, screw fixation. We can do everything. And my experience for the navigation system is expensive but useful. You can prevent mislevel, and we can very easily make sure the levels, SAP, IAP, every place we can make sure very easily. And during the cage insertion, it's very helpful to direction and depth and the tiltings. This is showing the why bipolar BK, how we can we put only cage, because under the endoscope view, we can see the medial wall, lateral wall of pedicle, and extend node, everything. This is I am putting the autobone, which is came from IAP. I like to take IAP with a big size like this. And this is endoscopic. Endoscopic fusion is early stage. Endoscopic discectomy is stabilized, and endoscopic decompression also past the plateau. But he is only here, so we need a complication paper or clinical data. But the papers and other things for bipolar interbody fusion is bursting stage. Yeah. So I believe the cage. If there are severe disc space collapse or severe adhesions, expandable cage is very, very useful. But if your patient has a big body and the height is good, you can put only cage. It is depend on the clinical situation. Thank you so much.
Wow. Thank you very much, Professor Park. And last 3 days were awesome. And so many lectures, so many demonstrations. We all loved all of your tips and tricks. Thank you very much. Yeah, any comment? Yeah, fine. Thank you very much, sir. So with great applause to Professor Park and Professor Kolesov.